Cheryl, thank you. And it's really great to stand here because this has been a trial that we were desperate to do. And in fact, it's funny, yesterday when I was talking to Peter Calverley, he said, this is a trial that we wanted to do 15 years ago. Nick Hill said, this is a trial we needed to do and get published. So it's really important for us to understand the impact of this trial that we think will have on clinical practice, and really to understand what the data tells us, what the data of this trial tells us, because it's really important to understand that aspect rather than just looking at the Kaplan-Meier plots and what they mean to your patients. I just put up my conflicts of interest. So how did it all start? Well, this was really important for me to get across, but this was not a quick study. In fact, the first meeting we had was on the 15th of May 2007 as the trial steering committee. And then following that meeting, we then put a design of the trial, we put a grant application, we got funding, and we enrolled the first patient in February 2010. And Paddy and I still remember the first patient we enrolled in that study. So this was really, really, really tough to get going. We did get it going, and we enrolled that first patient. The last patient was recruited in March 2015. Database got closed, and I remember when I landed last year from the ATS, and on my phone was the data that we had from the study. And I landed, and I opened it, and because I'm the last person on this earth with a BlackBerry, I opened it, but I couldn't actually see the Kaplan-Meier. I saw two colors, they looked very separated, so then I had to ring Paddy and say, I'm hoping the separation is because we've had a treatment effect that's substantial. And indeed it was. And after going through the whole of this process, we submitted in September last year. And in fact, the paper was only accepted for publication 3 weeks ago, which is why we did the simultaneous presentation and release on Sunday. So for those interested, this is published now in JAMA, it's free online. There's a fantastic editorial by Nick Hill. For those who are interested in altmetric score, it's already got an altmetric score at 574, which puts it in the top 1%. And that's for not just the associated with the age of when it was released, because it's only 48 hours ago, but over total JAMA publications. So the trial. What do we want to do? We wanted to take the severe sick COPD patients and see whether the addition of home mechanical ventilation to home oxygen therapy would improve the outcome of the patients. This is UK data, and really what we're seeing here in this Kaplan-Meier plot, if a patient is sick, comes into your hospital, gets acute non-invasive ventilation for hypercapnic respiratory failure, and then goes home, 40% of those patients are dead at 1 year. This is a really bad condition. If you're severe enough to require acute non-invasive ventilation, afterwards, and you go home, you remain persistently hypercapnic, you're very likely to die. And in fact, worse than that, your time to readmission was in 32 days, and this is the data we used to power the study. So how did we design this trial? Well, what we were focused on was to capture patients who were most likely to benefit. We wanted to enrich the cohort to identify the patients who were most likely to have some improvement. And so we took patients with an exacerbation of COPD. They required acute non-invasive ventilation in the hospital. They then went home, and we saw them at 2 to 4 weeks after the admission. And we identified the patients who had a high CO2 level, and their CO2 was greater than 7, or 50 millimeters of mercury. So these patients, as we all know, have a high likelihood of death or readmission. We wanted to take the patients who are hypoxic and hypercapnic at 2 to 4 weeks after admission. And we wanted to use home oxygen therapy and home mechanical ventilation together to see if that proved to be beneficial in terms of admission-free survival. I'm just going to explain that, and we had lots of discussions with JAMA about this, because this is the time to readmission or death. And it's a composite endpoint, because what's important to the patient is readmission. What's important to the patient is death. So we use very, very patient-centered primary outcome. We took patients who were very sick. These patients had severe COPD. They'd had a life-threatening exacerbation of COPD, so severe they required acute non-invasive ventilation. They didn't have any evidence of sleep-disordered breathing. In fact, part of our inclusion criteria or exclusion criteria was the patients who had a BMI greater than 35. We didn't want overlap patients. We didn't want COPD OSA, which is much, in my personal experience, easier to treat than the pure COPD patients. And we gave it during the recovery phase. So these patients have very limited treatment options available to them. And the concern was, these patients may have been too sick for any treatment effect to occur. Because there's a tipping point where a patient may have such severe disease that whatever we do may not help. So this is the consort diagram, standard for all clinical trials, and I'm just going to run through a few slides which will go into this in a little bit more detail. 16% of the patients said, sorry, I don't want to be part of a trial. And that's an interesting, because some of the patients actually were recurrent readmissions with exacerbations, as we see. And in fact, the more patients or more times you got readmitted, the more likelihood you were going to join the trial. And I think that goes to say about the effects of acute NIV on patients and how they do not like it. We had 39% of the patients were palliative end-of-life care, and indeed 16% of the patients were discharged home on non-invasive ventilation as not part of a trial, but because they remained persistently acidotic if we stopped non-invasive ventilation. So really important that some of these patients were too sick for us to remove the non-invasive ventilation. We excluded 11% of patients with OSA and a high BMI, and 26% of the patients, so 419 patients of the 2,021 patients, actually didn't have a CO2 that was elevated when we saw them. Really important. We're putting patients on home oxygen therapy, and they're coming back to us in 2 to 4 weeks, and their CO2 had normalized. Really important in prognostic terms, because these patients are ones that actually, from previous data, do better. So 50% of the patients, when they came back, didn't have persisting hypercapnia. If you don't have hypercapnia, there's no point giving somebody a ventilator, because you need to be in ventilatory failure to receive ventilation. So the intervention and the control group. So HOT-HMV, home oxygen therapy, home mechanical ventilation versus home oxygen therapy. Primary outcome, admission-free survival at 12 months, time to readmission or death. And we obviously had a number of secondary outcome measures to understand the mechanistic parts of the effect, if we saw an effect. We had titration of the non-invasive ventilation. This is part of the online supplement that you can find in JAMA to just guide you through how we set the patients up with COPD on non-invasive ventilation. Important to get that standardized. We need to see whether the intervention is being delivered. When you think about a clinical trial and you think about the effect of a clinical trial, you need to make sure that the intervention is being delivered. And what we actually had, and I think what's important to take home, is when we looked at the patients, they were on an IPAP of 24, an EPAP of 4, they had 1 litre per minute oxygen therapy with a backup rate of 14. That's how the patients were set up. This wasn't necessarily high pressure or high intensity, this is moderate pressure without a backup rate. We did have a treatment effect in terms of the intervention was working. The carbon dioxide fell over the year. We saw a decline in this CO2, this is transcutaneous CO2, of the patients who are on non-invasive ventilation. At the beginning, at the first 6 weeks, they were using it for 4.4 hours. By the end of 12 months, they're using it for 7.6 hours a night. So the patients are using this and they're becoming increasingly adherent to the treatment over time. When we look at the gases, if we look at the PaCO2, the arterial carbon dioxide, we see at 6 weeks and 3 months, there was a difference between the control group and the treatment group. However, that difference was lost by 6 months and 12 months. And the importance for looking at the data in detail is to know that 29% of the patients switched from the control arm to the treatment arm. When somebody had hit the primary endpoint, which is the most important part of any clinical trial, if the clinician or the patient suggested they wanted to start non-invasive ventilation in their home, they were allowed to. And that can be a discussion point of whether we should have done that. As a purist and a trialist, we should have never have done that. As a clinician, I think it's up to the patient if they're requesting treatments. But we did, we allowed them to cross over. And because we crossed over, we diluted our effect slightly. So all the data you'll see, secondary outcome, has a diluted effect. So this is the primary endpoint, this is the primary outcome, time to readmission or death. There is early separation within the curves. What we see is the time to readmission from 1.4 months to 4.3 months. There was a 50% reduction in readmission or death by use of the treatment. There was an increased time to readmission, which is really very important. When I look at the primary outcome, in fact, there was no difference in mortality. The signal is all around readmission. The mortality at 12 months in both of the groups was around 30%. The mortality at the primary endpoint was around 10%. The driver of the difference between the treatment and the control group is wholly based on the readmission. So we need to treat 6 patients to prevent 1 readmission or death, but the data would actually say you need to treat 6 patients to prevent 1 readmission. What happened to quality of life? We've got studies, the AVCAL study from Australia, that actually showed a detrimental effect on quality of life. We actually saw an improvement over the first 6 weeks in quality of life. But there was no difference in quality of life after that stage. Really important to remember that 29% of the patients crossed over. We diluted out our effect because our goal was focused on the primary outcome. But we see here that over the first 6 weeks, there was an improvement, but importantly, there was no detrimental effect on health-related quality of life. exacerbation rate. Really important. We actually hypothesized that the patients would exacerbate the same, but because they had a high dependency unit in their own with non-invasive ventilation, oxygen, antibiotics, they could do it all at home. Well, we were wrong. And we were wrong because we reduced exacerbation frequency. And we reduced exacerbation frequency by 1/3. In addition to reduction in exacerbation frequency, we were interested in 28-day readmission, which is now a priority for healthcare. In the UK, the US, and many other countries, there's a financial penalty if you get readmitted at 28 days. So within policy, we were very interested to see what the 28-day readmission was. And indeed, what we actually found from the data over the first 28 days, that we reduced readmission risk by 2/3. Really important data. The rescue study, the Dutch study, was very similar in design to this study. So what's the difference? Well, the difference is, and they had obviously a negative study, which didn't show a difference, but the same primary outcome. The comparison between the rescue study and the HOT-HMV study is that the patients in the rescue study were not as sick, or in fact, they'd hit a period of recovery. We saw patients at 2 to 4 weeks and their carbon dioxide was 50 millimeters of mercury or 7 kilopascals. In the rescue study, they initiated people in hospital if their CO2 was greater than 6 or 45 millimeters of mercury. And so what actually, when you look through their data, they had resolution of the control group by 6 weeks. And so what we've done here is taken a sicker cohort of patients. And it's really important that when you're a trialist and you're going through lack of effect, you go through the PICO questions, the target population, the intervention, the control, and the outcome. We had the same outcome, we had the same control, we had the same intervention. Their intervention on the patients that received non-invasive ventilation drove down their CO2, as did ours. It's the target population that is different. But how does it work? I think this is a really important question to ask. And I think if you've got persisting hypercapnia 2 to 4 weeks after you've stopped acute NIV, you need to be treated with home oxygen therapy, home mechanical ventilation. That will treat the chronic respiratory failure. That will reduce exacerbations. And the way that may reduce exacerbations is the effect on neutrophil function, obviously a hypothesis, and this is all based on animal work. Reduction in 28-day readmission. Enhanced health-related quality of life, in the early stage at least, but no detrimental effect on quality of life, with a 50% reduction in 1-year readmission or mortality, and it's actually readmission that it's affecting. So as a clinician, how's this going to change our practice? So this will provide the evidence and the data that the addition of home mechanical ventilation to home oxygen therapy in a patient that has a high CO2 2 to 4 weeks after an exacerbation requiring acute NIV will benefit from home mechanical ventilation, home oxygen therapy. You'd only have to do it in 6 patients to prevent 1 readmission. It's going to drive us to admission avoidance rather than having a mortality effect. But we will be reporting back to you on the mortality effect because now we have the data from 1 year, 2 year, and 3 years, and we will be collecting the 5-year data set. But we will understand what the effect is on mortality in the longer term rather than the 12 months. But readmission is a very important target for treatment currently. And clinical practice, well, you can use high-pressure non-invasive ventilation in those that remain hypercapnic. We'd say a cut-off of a CO2 of 53 millimeters mercury with an oxygen grade less than 55, you should consider adding in non-invasive ventilation to oxygen therapy. I'd obviously like to thank, most importantly, the patients that took part in this trial. These were sick patients, and in fact, we had very little in the way of dropout from this trial, which is testament to the patients as well as the trial team. The home oxygen therapy, home mechanical ventilation trial team in the UK and the home mechanical ventilation UK network. There was a number of funders and sponsors involved with this. This study went on for a protracted period, but we all knew that it was important to get the answer. I'd like to thank you for listening.